So I talked yesterday was kind of like the principles of why do we pre-medicate and pre-anesthetic medications or anything given before induction. And now two of the main categories we use, well, sedatives slash tranquilizers kind of go together. You're either going to give a sedative or a tranquilizer. We usually use some type of analgesics. And then we do plus or minus adjunct anesthetics. So if I'm getting into, there's a category of anticholinergics. Anticholinergics are typically considered an adjunct because they aren't a sedative, they're not a tranquilizer, they're not an analgesic. We are giving them to treat a problem or try to prevent a problem. So they're parasympathetic, okay? Parasympathetic, basically anticholinergics go against the parasympathetic system, and anesthesia puts the animal in a parasympathetic state. So if you remember your neurology, and when we talked about drugs and the sympathetic and parasympathetic system, basically things slow down in the parasympathetic system. So they block the action of acetylcholine. Anti-chol. Are you seeing the connection? So the main reason that we give these drugs that you need to know is we're either going to prevent or treat bradycardia, and we want to decrease salivary secretions because most of the time different anesthetics will cause an increase in salivation because that's one of the things that happens in the parasympathetic system is we get an increase in saliva. Now at times, we don't want that saliva. Excess saliva can interfere with intubation. It can clog up the endotracheal tube. On recovery, it can cause issues. So, but the one thing I want you to know about anticholinergics, if you give them with the pre-med, at the same time you give the sedative and the analgesic, you're giving it to prevent. A lot of times, I don't give atropine with the pre-med. I will sometimes give it if the patient becomes bradycardic or too bradycardic during the procedure. So then I'm treating it. So I want you to know the difference between when I give it for prevention and when I give it for treatment. I'll give you an example. Cows have a lot of excess salivary secretions because of their digestive system. So a lot of times we will pre-med a cow. Sometimes if I have a cat that's salivating excessively, we will pre-med that cat. But I know if I'm using it for saliva reasons, it's also going to affect my heart rate. So the two drugs that you need to know are atropine and glycopyrrolate. Those are the two anticholinergics that we use. They can be used now it says dogs and cats, but you can use them in other species. You can give these IV, IM, sub-Q. The only time I would use transtracheal is if I was in an emergency like a CPR and I cannot get an IV in my patient. So that's the only time I would use these drugs transtracheally would be in CPR. Now, I'm going to give you a tip when it comes to pharmacology and drugs and a tip for anesthetic agents. Right now, and this is very important, so I hope everybody's listening to me and paying attention. Anticholinergics are a family of drugs, okay? What does the family do? For example, we are the Landeros family, okay? What do we have in common? We live in the same house. We have the same last name as my husband, okay? What are the differences? Well, I have two kids. I have a boy and a girl. They do different things, okay? What do they have in common? They belong to my family. I gave birth to my two kids. Obviously, they aren't the same. I know this sounds strange, but when I think of drugs, there's drugs that belong to a family. The family of drugs does this. They have that in common. Anticholinergics prevent or treat bradycardia. They decrease salivary secretions. But why would I have two drugs in the same family that do the exact same thing? There has to be differences. So there was differences between atropine and glycopyrrolate. They would not make two drugs that do the exact same thing. Is everybody following me? Because when you guys study drugs, there's a drug family, and then there's differences in those drugs. So atropine and glycopyrrolate have in common the reasons we give them. But what is the difference between atropine and glycopyrrolate? Well, first of all, atropine works faster. It has a shorter peak and a shorter duration. And atropine is dirt cheap. A lot of times I compare drugs by cost because in veterinary medicine, we're not very lucrative. We don't, so sometimes we are bound by the cost of medication. Sometimes a doctor carries a certain drug because it's cheaper than another drug. So first of all, atropine's been around forever. It's very, very cheap. Glycopyrrolate, this is the way I remember it. There's a lot more letters. That means it's a lot more expensive, if that helps you remember it. Glycopyrrolate came around. It doesn't kick in as fast, but it does last longer at its peak, and it lasts longer as its duration. Now, I don't really have you memorize in general how long drugs last, because sometimes it depends on how you give them. Remember, if you give something sub-Q, it's going to last longer than if you give it IV. So route of administration has something to do with how long drugs last in the system. But longer word, longer duration. It applies in this case. It doesn't apply for every drug, but in this case, if that helps you remember, glycopyrrolate lasts longer, but it doesn't kick in. But I'm going to tell you an important thing. Atropine is the drug of choice in emergencies. If I have a severe bradycardia, like if I have a patient that's heart rate, if they have a vagal stimulation and their heart rate plummets, or we think we're headed into like cardiac arrest, I'm going to give atropine because I know atropine is going to kick in and it's going to do the job. Glycopyrrolate does not kick in as fast, but what I like about glycopyrrolate, two things. It does not cross the placenta. So if you're using atropine in a C-section, the fetuses are going to get a little bit of this medication. But in the glycopyrrolate, it does not cross the placenta. The other reason I like it, it does not kind of jack up their heart rate as fast as atropine. So in geriatrics, I worry sometimes when we use anticholinergics that I'm going to make their heart go too fast. And when I have an older dog and maybe we don't have a full cardiac history, sometimes heart disease in patients goes undetected and it's minor. So if I had an old cat for a dental, like so you have again an old geriatric cat and sometimes with dentals and they drool, I would use glycopyrrolate because it's, well, and the other thing, very good point, Michaela. I love that analogy, G for geriatric. I'm going to use that from now on. G for geriatric. Glycopyrrolate is not going to jack up their heart rate as much. And I did not put this on the slide. Glycopyrrolate is a better drying agent. If I'm worried about a lot of saliva, glycopyrrolate is going to dry them up better than atropine. So do you see, I have two drugs that I basically use for the basic same reason, but there's the little differences of when I would choose one versus the other. When I give a test, and how I want you guys to understand these drugs is what makes this drug different from this drug. Again, they're going to do about the basic same thing. I mean, if I had an emergency and I had no atropine and all I had was glyco, I would use it. But I can't think of, atropine is a staple in every crash cart or emergency drug box you have in a hospital. So basically, every time we have an emergency, you want to have atropine. So I don't think I've ever been at a practice and we've not had atropine. Now, glycopyrrolate, I will tell you, not every practice carries glycopyrrolate because, again, it is expensive. And recently I had heard clinics couldn't get it. Someone told me it was off the market, and then I had heard it was coming back on the market. So to be honest, I'd have to ask some friends of mine that are in practice, can you get glycopyrrolate right now? But for like a board exam or for a test, I want you need to know the difference. Whether you'll ever work with it, I don't know, because not everybody carries it. But, you know, we carried it in anesthesia. Now, what I will tell you, okay, some of the effects of anticholinergics, they say it can depress the CNS, but this, I've not given enough atropine, or we're using it dose after dose after dose where I'm going to see this CNS depression. And often they're already anesthetized. But in the book, and when you look up this drug, it does have CNS depressant effects. It prevents bradycardia. This you have to burn into your brain. If that's the number one reason that we are either treating a patient pre-op or giving it intra-op. And it's going to dry up secretions. Now, because it dries things up, it may also dry up the eye and cause some corneal drying. So if you have a patient that has dry eye already, or keratoconjunctivitis, KCS, if you learn that with your eye diseases, then that can be an issue. And it's also going to cause some bronchodilation. So those are things that the anticholinergics in general are going to do. There's good notes underneath these slides, so make sure you look at those. Now, when I talk about adverse effects, yes, they're playing in the other room, so he needs to take a nap like quick. So, the one thing, and I really want people to highlight this or put a star on slide 16, because whenever you give atropine, you can see cardiac arrhythmias. And one thing here is it increases myocardial consumption. Whenever you make the heart beat faster, you're making the heart work harder. The myocardium is a muscle. You're giving a drug and it's making that muscle work harder. That muscle is going to consume more oxygen. So we have to make sure our patient is oxygenating. We have to make sure that our patient has good color and no respiratory distress. You can see some of this. If I have an animal that already has an elevated heart rate or any heart disease, I tend to not use the anticholinergics unless it's an emergency. Let me give you an example. Hyperthyroid cats. I have a hyperthyroid cat. Hyperthyroid cats usually come in very tachycardic, and sometimes they have thickened heart muscle. So they already have an issue with, did you want to say hi? You're being very loud and they can hear you. Stinker, you're being a bad boy. Huh?
Keeps getting past the board.
How is that happening? Hang on, guys, 1 second. Sorry. He is getting big. Bo's getting a little more grumpy with him, so I was just warning my daughter to say, like, twice the puppy's come up behind Bo when he's been laying down and sleeping, and like last night he kind of went like back at him, and I was like, and Bo kind of curled his lips, and I was like, oh. So they've been playing really good, but in the last 2 days I've seen, like, I got to kind of watch Bo and make sure I think he's just trying to teach the puppy manners, hopefully. Okay, let me get back on this because, again, geriatric cats, hyperthyroid cats, usually come in with an already elevated heart rate. So I don't want to do anything to elevate their heart rate more. If I have a dog that has dilated cardiomyopathy, their heart is dilated, the muscle is weak. If I do something to make the heart work harder, I'm going to potentially see more arrhythmias or more side effects. So again, if I have a patient that's already tachycardic, I'm not gonna use this drug. Now, that being said, I told you guys the story where we gave it to a Newfoundland and his heart rate went up to 220. So sometimes you give it and their heart rate goes way too high, and then you have to treat the symptoms. There's no reversal for these drugs. When you give atropine or glycopyrrolate, if you see any side effects, you are stuck with these adverse or these side effects until they wear off. Now, atropine sometimes causes this weird thing where you start to give it, say their heart rate's low in surgery. We usually give a quarter to a half dose when we first give it. We don't usually give a full dose because sometimes a quarter or a half dose is enough. What happens is you give it and then the heart rate will start to drop before it speeds up. It's kind of like, I think of it like if your car was completely out of gas. When you first put gas in your car, it kind of is like, it's like sputtering and then it starts to go. It's kind of like, that's what it reminds me of, is like my heart rate was slow. Sometimes I'll get this initial dip and then it'll speed up. Atropine is the drug of choice for when you have second and third degree heart block. When you have a bradyarrhythmia like those heart blocks, you are going to treat it with atropine. Okay. So I'm cautious. And now if I have an animal that already has thick salivary secretions, sometimes cats, I like when their drool or their saliva is really loose. And I like when, or like a lawnmower, that's true. But when they have that really like loose watery drool, that's fine. But sometimes like bulldogs and cows, they come in and they have this very thick, ropey saliva. And if you have this thick, ropey saliva, those guys, if you give a drying agent, it can make their secretions too dry, okay? To the point that it basically can turn into like an airway blockage. So if I have a patient, I had this bloodhound, we were doing foreign body surgery, and he was dehydrated and he's drooling because he's a bloodhound, but it was very sticky drool. It wasn't like loose. And, now luckily he was a big dog and I had no reason to give him atropine, but he's one, if I have to suction these guys' airway in an emergency, I want that to be a loose secretion versus sticky. That's what I mean by airway blockage. So again, it's, and I get feedback from my doctor. I'm like, should we give atropine? Should we not? And I've had doctors give me authority if I want to give atropine or not. As you get more experience, you can make that call. The other thing it does is it inhibits peristalsis. So what can happen, because you're putting them in a sympathetic state with this drug, sympathetic, remember, the GI slows down. So when you give these drugs, you have to be cautious in horses because horses need their GI tract moving. In ruminants, it can cause, now one dose, maybe not so much, but we worry about slowing down the GI tract of these fermenting animals. And guinea pigs are kind of like a mini horse. So their GI tract is very similar. And hopefully you guys learned in exotics that rabbits have an enzyme called atropinesterase, where it will break down atropine and render it inactive. You can give atropine to a rabbit. It just may not work. And normally their heart rates are very high, so you don't usually need to pre-treat exotics for bradycardia. But the big take-home message, let me say this. Any of these contraindications, if you are in an emergency in surgery with bradycardia, you have to give it. You can't worry about, you can't be like, oh, my patient's dying, but I don't want them to bloat. You have to give the drug. So there are situations where you maybe didn't pre-med with it or use it, and then all of a sudden we have to use it because it's an emergency. Now, let me give you my personal opinion. I am not a fan of pre-treating or giving anticholinergics routinely. Okay, there are some doctors that want to give everything a shot of atropine because they worry about heart rate. Think about the heart's job. The heart's job is to adequately pump to maintain blood pressure. I have had animals, and I worked for an anesthesiologist and a criticalist for many years. Very smart doctors, okay? Their theory was, and they are who trained me, that if the heart rate is low, but they are maintaining perfusion and blood pressure, that is the ultimate goal of a heart rate, is to maintain adequate perfusion to my patient. So I've had low heart rates, and my boss is like, well, what's their blood pressure? And I'm like, well, their blood pressure is great. And he goes, then I'm not worried about it. It's when we worry that it's dropping too low. Now, I will tell you, doctors have different comfort levels with heart rate. Dr. Ritz doesn't like a low heart rate. I think Dr. Paul's a little more tolerant. And my oncologist that I worked for, she hated the low heart rates. But it's all comfort level. So obviously you have to do what your doctor tells you. I'm going to tell you physiologically what the drugs do. I'm going to tell you the opinion that I was trained under, but I will tell you, you will work for doctors that may want to give everything atropine or treat a heart rate of 100, which, I have a very high comfort level with low heart rates, but I use my other data to evaluate that heart rate. Now, I'm going to jump ahead a little bit because you guys are going to use a lot of dexdomitor at school, and practices use a lot of dexdomitor. Dexdomitor causes a severe bradycardia because of what the drug does. I don't treat that with atropine because that is a drug-induced bradycardia that's coming from the drug. I will treat bradycardia that's from hypothermia, increased anesthetic depth, vagal stimulation with atropine. But if it came from dexdomitor, we will usually let the dexdomitor wear off and see what the heart rate does. So when I come to dexdomitor, I'll talk about that. Okay, so are there any questions about the anticholinergics? Why you give them? What are the difference between the two in the category? And you have to be able to tell me, because put yourself in my shoes. As a teacher, I'm like, what's the difference between this one and this one? Right? That's what I need to know, is what is the difference between the two. Okay. So a lot of notes under here. There is a note at the bottom here that atropine can come in different concentrations. Atropine, I will tell you also, atropine comes as a grain concentration. When you look at the bottle, a lot of clinics will calculate on mils. They'll say a mil per 10 pounds. At school, they give you, I believe, a concentration of atropine. You will always calculate a dose of atropine for every patient going under anesthesia in case you have to give it. So that's, again, another role of the anesthetist. Know your atropine dose, because if you have an emergency, you don't want to be like digging out your calculator and then like trying to find the dose. You will have that dose already calculated. So if you have to give it, you grab the bottle and you give it. Okay. Now, let me move on to the next category. And tranquilizers and sedatives are like a family. And again, it's a little confusing because people use these words interchangeably. Remember, a tranquilizer is going to reduce anxiety, maybe not awareness, but sedatives are going to decrease mental activity and have varying levels of sleepiness. But A tranquilizer can be given, like I said, we usually tranquilize big cats at the zoo, and they will be very out where they look like they are not aware. So again, with these drugs, it depends on the level that you are giving them. But these are the categories of drugs that are under the tranquilizers and sedatives. Now, phenothiazines, benzodiazepines, alpha-2 agonists, and alpha-2 antagonists. Now, there's some notes here at the bottom. Let me explain this. And I usually write this out on the board, but when I make a pre-anesthetic protocol, I choose a tranquilizer sedative. I choose one. I choose one analgesic, and then I decide if I'm going to give atropine or an anticholinergic. You're not going to give acepromazine and Valium to a patient. That's like a double negative. Do you see what I'm saying? Because you'd be picking two drugs from the same category, tranquilizer sedative category. Normally, you're going to look at all the drugs you have in your hospital that are tranquilizers and sedatives, and you're going to pick one. It might be ACE. It might be midazolam. It might be dexdomitor. This is when we're going to get into patient factors and why we pick one over the other. It's kind of like if I when I do my soup, I pick a salt, I might pick an herb, and I might pick like a bouillon. But I might not pick more than one. That's maybe not the best analogy. But do you see what I'm trying to say? Make sure we choose one category. Phenothiazines are a group. The main one we talk about in anesthesia is acepromazine. Acepromazine, phenothiazine. If you've ever heard of a drug called chlorpromazine, sometimes it's used in allergies, but it does live in this category. It has azine in it, phenothiazines, but the main one I'm only stressing is acepromazine. People call it ACE. The trade name, there's one called Promace, Promace. So when you guys look it up for your drug project, I said acepromazine is the generic name. And then when different companies, acepromazine's been around forever. It's dirt cheap. Okay, so this is another one that's really cheap, but it's the only one I'm talking about in this category. Different companies have made their own acepromazine. So when you order it from Fort Dodge, which is one of the most common companies we use, it comes as Promace, but it might be called something else from a different company. So hopefully that makes sense. The reason we give ACE is to sedate them, to calm them prior to anesthesia. The goal, if I pre-sedate them, I'm going to use probably less induction agent and less anesthetic gas. The more calm my patient is pre-op, it's called anesthetic sparing. If I can pre-sedate them, I'm not going to need as much induction agent. So it decreases my general anesthetic, it decreases my induction, and it hopefully helps them recover. I'm going to tell you, acepromazine IM is going to probably give you 2, maybe 4 hours of sedation. So if your surgery is done in an hour, from the time you pre-med, if you're out of surgery in an hour, you still have 2 or 3 hours of this drug hanging around. So hopefully they're going to wake up more calm. And hopefully everybody understands that as well. So easier induction, easier recovery. It can be combined. A lot of times ACE is combined with an opioid for like minor procedures like a laceration, a pre-med. But I'm going to tell you, and I don't know why it is not analgesic. There is no analgesic effect to acepromazine. Acepromazine is good. Remember I talked about you might have a cat that's kind of not agreeable, and the owner says, I want it to be shaved down and trim its nails and give it its vaccines. You can give acepromazine because none of those procedures are painful. You just need the animal sedated so that you can handle them. But if I was going to do a laceration repair, say they cut their leg on a fence or got in a dog fight, if you give acepromazine, It may calm them for the procedure, but it's not going to treat the pain. So if you're going to do something painful, and the reason I warn you guys is a lot of clinics will give them ACE and then say they hurt their leg. Okay, they fell off the deck. They're like, the doctor says, give them some ACE, take some x-rays. If the leg hurts and you pull on the leg for an x-ray, they can react. And anything that bites you that is sedated is biting you and is unaware. So I always have a hand on their head. I always say hold them when they're sedated, because they can fall off a table, they can bite, they can react. But if you're going to do something painful, you should be giving ACE and an analgesic. You can use it horse, dogs, cats, multi-species. It's typically better IV or IM. Remember, if you give it IV, you're going to see more of the side effects. You can give it sub-Q, and if you want to write to the side or put a note, it can be given orally. You can use, there's a note here at the bottom. It comes as an injectable and tablet form. You can give the injectable orally. If you have a cat that's aggressive, you can squirt it in its mouth and it will get absorbed. My friend, she had an Airedale that had really bad storm anxiety, and she actually used sublingual acepromazine liquid injectable orally for storms. It helped calm him for storms. Now, most people will sell clients the tablet form. Now, it's really good for storm anxiety, fireworks. I used to joke at my first practice. I said, yes, that's what they give. I said, I used to, around the 4th of July, I said, can I just put the acepromazine in the little gumball dispenser so clients can just like put in a quarter and get a handful? Because I was filling acepromazine so much like the week before 4th of July. I'm like, oh my gosh, another prescription to fill, another prescription. So acepromazine is used a lot outside of anesthesia to calm the patient at home for anxiety. The thing also to know, there is no reversal agent. So any side effects that you encounter, you have to treat the symptoms because you cannot take it away. That's like when I give acepromazine, and I think I said this day one of anesthesia, if I'm unsure of a dose in a patient, you can start low because you can always give them more, but you cannot take it away. It's like when you put the salt in the soup, I might cut the salt in half because if I taste it and it's good, I don't have to give any more. But if I put the whole amount of salt and then I'm like, crap, I've ruined my soup, I'm stuck with it. I can't take my salt out of the soup. Do you see what I'm saying? So if you're concerned about a patient, I recommend, we always can go on the lower end and you can always give more. You can always give more. It does require liver metabolism. So, ideally your patient would have adequate liver function. What do you think would happen? Say, for example, a client doesn't want blood work. I have no idea about their liver function. And say they had liver issues and I gave acepromazine. What do you think that's going to do to my patient if I give ACE and they have inadequate liver function? And there's going to potentially be toxicity. What's that going to do to the duration the drug's going to last in my patient? It's going to last longer. So what Kirsten said, I have a potential for more toxic side effects, but I also have the potential that it's going to last longer because the liver, most of these drugs I'm going to talk about, the liver biotransforms them. And the kidney will, liver and kidney go together. The liver will biotransform them or render them inactive. And then the kidney will usually clear them, or some will go out of the bile. So if I do not have adequate liver and kidney function, one of the big things I worry about with anesthetics is a prolonged duration of effects. If I know ACE lasts 2 to 4 hours, is it going to last 6 to 8 hours? If I have an owner that wants to come pick up this animal and I go to wake them up and they're like still sleepy, I have to think about that. So that's why it's always good to Try and decrease the dose, see what you can get away with. Now, the main effects that I'm looking for, it's going to calm the central nervous system. It's going to sedate them. Hopefully they're not going to move or want to move as much and be a little uninterested in what's going around them. It produces less sedation in cats. Usually, oh, this is another thing. What's interesting is the dose of acepromazine in cats is higher than it is in dogs. Does anybody know why? Why would the dose mg per kg, the dosage mg per kg, be higher in a cat than it would a German Shepherd in mg per kg? Metabolism. Okay, perfect. So what you will find is when you look up dosages for a dog and a cat, it is not abnormal to see that your dosing is going to be higher in a cat. The dose is going to be high, the dosage in mg per kg is going to be higher for a mouse than it is a cow. What you draw up for the cow is going to be more because of size. But the smaller the animal, the faster the metabolism. Okay, so you got to pay attention to your dosing when you look at that. And again, not an analgesic. If you do something painful, somebody needs to have their hand on that animal because they can react. Big thing that you need to know, it's a vasodilator. Acepromazine vasodilates them. So it makes the blood vessels bigger, and that can lead to low blood pressure. One of the reasons sometimes doctors don't want to use ACE in pediatric and geriatric or ill patients is because they're usually going to have worse hypotension and lower blood pressure. I like ACE a lot. ACE was like one of our main pre-meds when I was at Purdue. But I always tried to use a low dose, and I was always aware to be checking my blood pressure because when you use a vasodilator like ACE, it can cause that. Now remember, anytime you have low blood pressure, you can see an increase in heart rate because the natural reflex is to hypotension is for the heart to beat faster. You just made the pipes bigger. Remember I said the heart wants to fill the pipes, okay? When you make the pipes this big, the heart's like, oh, I got to fill them up. They're bigger now. So the heart starts to pump faster to try and accommodate for low blood pressure. Now, I always just warn students about that because when people see a high heart rate, they automatically assume it's pain or they assume the animal's getting light. But if your blood pressure is falling, it can be that relationship. And anytime you vasodilate them, you increase the chance of hypothermia because when they dilate, the vessels give off heat and you can lose body temperature. So keeping them on a towel, keeping them covered. Now, the one thing that acepromazine does that's kind of a nice benefit, it can have some anti-arrhythmic effects. Now, that doesn't mean I have an animal with an arrhythmia, I give it acepromazine. But if I'm using an agent, sometimes ketamine can cause some arrhythmias, some tachyarrhythmias. I like to give ACE with ketamine because the ACE might give me some protection. And it can decrease cardiac output, which at times of high blood pressure could be beneficial. Now, the respiratory system, remember, anytime you sedate an animal, they're going to be respiratory depressed. Anytime you give them an anesthetic, they're going to be respiratory depressed. Whenever you give ACE with morphine or ACE with butorphanol or ACE with this drug, it's usually going to worsen the depressive effects of the drugs. They potentiate each other. It's kind of like when spices work together. You give this spice with this spice because you can use lower doses, but they work together to enhance the flavor. When I give ACE and butorphanol, ACE by itself is butorphanol by itself is ACE and butorphanol together work synergistically and they enhance, but they can enhance some of the depression. The other nice thing is acepromazine is antiemetic. A lot of my anesthetic opioids will cause some vomiting, drooling, nausea. Acepromazine will help counteract that. That's one of the reasons. Now, I will tell you, now that Cerenia is on the market and Serenia is so popular, most of the time, if we have a client that said, my dog throws up in the car, they're anxious in the car, most of the time they're given Serenia now. But we used to prescribe acepromazine for car rides because it'll calm the patient and it has some anti-emetic, which is, emetic is vomiting, so it has some anti-vomiting properties. Now, if I have a dog coming into emergency with GI upset, I'm not grabbing acepromazine because remember, ACE number one job is sedate. Antiemesis is a nice little side. It's not, do you see what I'm saying? Because I've had students put that on a test and say, well, you told me acepromazine was antiemetic. I'm like, that's not its primary use. That's one of the neat little side things. If you have an animal, like when we have dogs getting chemotherapy, every chemotherapy dog goes home on Serenia because Serenia is an antiemetic. We don't send them home on acepromazine. Every chemotherapy patient has a box of Serenia. So if they get sick after chemo, the owner can give Serenia and treat that. Okay. The other thing that's nice is it prevents histamine release and it helps prevent allergic response. Again, I don't give this drug for allergies. You would give that dog Benadryl. But if I have a dog, I will tell you, mast cell tumors, you may have talked about these in ClinLab 4, maybe, mast cell tumors, or if you've heard of it. A mast cell tumor, no, the body has mast cells. Normally, mast cells release histamine. If a dog gets stung by a bee and has an allergic reaction, the mast cells release their histamine granules. Histamine causes the itching of the skin, the watering of the eyes. In severe cases, it can cause that swelling. When we have a dog that has a tumor of their mast cells, they are prone to histamine release. When I used to clip them for surgery, I had to be very cautious because if you just like push the tumor and squeeze it, it can cause a massive histamine release. So those dogs always got Benadryl prior to surgery because the surgeon is going to be like moving it. But I always like to include acepromazine in the protocol because acepromazine has some antihistamine effects. So it's just another added benefit. Again, a dog comes in with allergies or an allergic reaction, we're not giving it acepromazine. But if I'm worried about that and I need to pre-med that dog, that may be why I choose acepromazine. You're going to have all these drugs on a shelf, okay? Then I'm deciding why am I going to pick this one versus this one versus this one. So I'm trying to put you into like, what is the thought process of why we would pick ACE versus this drug versus this drug. So again, mast cell tumors, I'm like, you know what? I could give this dog dexdomitor. I'm going to give it ACE because I'm worried about histamine release. So that's just some of the indications. Now, let me give you, there are some adverse effects to acepromazine. It is contraindicated in patients that have seizures. If you have a dog that comes in that has a seizure history and you're doing an abdominal exploratory, acepromazine can lower the seizure threshold, which means it makes it easier for the patient to have a seizure. So if there's any history of seizures, it could be 1 every 6 months. Okay, that's the effect to the central nervous system. It can cause seizures. I want to bring this up. It may cause aggression or excitement, actually. Now, I worry about aggression, and I think of it this way, and this is how I explain it to students, and I caution clients. It lowers their bite inhibition. It takes away inhibition, but it's like a sedative. For you, you go to a bar, or you go out with friends, okay, for some drinks. When you first get there, you're like, you know, that guy's cute or that girl's cute or whatever, but you're kind of like, I can't go talk to them. I'm shy. I don't know. Will they like me? Then you have about 4 or 6 beers and pretty soon everybody's cute. And you're talking to this guy and this girl or whatever. It took away, the alcohol took away your inhibitions, right? Normally you had these inhibitions, but the alcohol took it away. The alcohol is altering your central nervous system and altering your inhibition. Liquid courage. I like that. Right? So let me take a dog that is nervous. They're nervous at the vet. They're kind of cautious. And then I give them a big slug of acepromazine because they look nervous. They're giving me that little eye, and I'm kind of like, I don't like the way you're looking at me. I give them acepromazine, and then I take away any inhibitions that that dog has. And then I do something they don't like. I stretch their legs. I flip them over too fast. I make a loud noise. Some animals on acepromazine respond more aggressively. Now, this isn't a reason not to give it, because when I want to give it, I give it. But I'm cautious around the patient because I know that I might take away inhibition. The big reason I tell you guys this story is that, we send this home with clients a lot, like for like the storms and stuff. But I always told my clients, I said, put this dog in a dark room, a laundry room, a bathroom. And I said, if you have kids, especially little kids, I said, I would keep them away from the dog, because if you have little Tommy jumping all over Fifi and Fifi's like on drugs, I don't want Fifi to bite or snap or act aggressively. So I always just warn clients, I said, sometimes on these drugs, they are not themselves. You would never think your own dog would bite you, but when we're on these drugs, I am cautious. So I always kind of explained it to clients that, this will be cautious. Let me skip down to prolapse. I know it says penile prolapse, but acepromazine causes prolapse, which means for to come out, of any nictitating or retractable membrane. Now, the penis is retractable. The third eyelid, you ever seen that third eyelid come up on your animals? So they've got their eyelids, and then you've got that little third eyelid. And now when animals are sedated, sometimes you can only see like half their eye, because acepromazine will cause that membrane to come up. Now that'll go away. But I learned very quickly in practice in high school, we gave this to a lady for her dog. She called us and said, oh my God, I think my dog's dying. His eyes are rolling in the back of his head. And we're like, oh my God, like, what are you talking about? All that happened was that third eyelid came up and she couldn't see her dog's eyes. So to her, it looked like her eyes were rolling back in its head. So I always tell the owners too, I said their eyes are going to look a little different. The little third eyelid, it should go back when the drug wears off, but they're not going to look normal. They may not act normal. That's not a reason not to give it. You want to warn clients, because when they go home and they give this and they see this might be like at midnight and they're home by themselves and they're like, oh my God, is this normal? They might not be able to call you. So I always kind of give them a little rundown of what to do, what to expect. We worry about penile prolapse mostly in horses. So acepromazine is contraindicated in stallions specifically. You worry about it. A gelding is a castrated male horse. Now, it could cause prolapse in a gelding, but a gelding is not being used for breeding. A stallion is usually left intact because they're used for breeding. And if we cause damage to the penis from prolapse, because when it prolapses, it's going to dry out. So you have to moisten the penis, you have to keep it clean, make sure it's not swollen if it does prolapse. So most people will not use it in stallions because they don't want to worry about prolapse. So remember, that's why it's contraindicated in stallions. Hypotension, and that I put dose dependent, because if you use a lower dose, you might not see as much hypotension. So I try to back off of that. It can decrease the PCV, because what acepromazine tends to do, it can cause the spleen to enlarge temporarily and suck up a bunch of red blood cells. So sometimes we'll sedate a cat with ACE because it's psycho, and we'll draw its blood. And it's like, oh, this cat has, oh yeah, Katie, you don't want to mess with stallions. Some of these stallions get good money for their semen. So that's a big worry. Equine medicine is a huge moneymaker. But I do want you to be aware, if you sedate something and you draw blood after you sedate them and you see a low PCV, you're probably going to need to recheck that after the drug has worn off, because it can cause that spleen to enlarge. And antihistamines, if you have a dog, I worked a year, believe it or not, in an animal dermatology clinic. So I did a year. It was just not my thing. Skin was way too boring for me. But we would sedate dogs for allergy testing when we have to do the skin test, because you got to put all the little pinpricks in their skin. We would never use acepromazine, because when we do a skin test, you need to see an allergic reaction. That's why you're doing it. So you don't want to give anything that's going to minimize the allergic reaction. So you would stay away from acepromazine. Now, dose and needle placement, all that's meaning is the dosage is dependent on where you're going to give it, IV, IM, sub-Q. I will say, when you sedate them on acepromazine, this is another soapbox thing that irritates me. Sometimes animals are given sedatives and they're put right in the prep room, in the room that you're doing surgery. Sometimes people have cages in their surgery treatment room, and everybody's loud and the lights are on, and it's going to take longer for those sedatives to take effect. It's ideal if you can put them in kind of like a darker room. Now, you want to be able to watch them, but sometimes I'll put them like in a kennel and I can dim the lights, or I put them in a darker room and I can kind of keep an eye on them. But the sedatives are going to have an increased effect if they're put in a calm, quiet environment. If you sedate them and you're holding them and talking to them, it's going to take them a lot longer to get sedated. It has an increased potency on the two ends of the spectrums, neonates and geriatrics, and if they're debilitated, like if they've had a trauma, if they have severe organ, like liver kidney disease. I always go really low on geriatrics. I go on my lower end of my dose. If the dose is 0.2 to 1 mg per kg, then you're going to go to like closer to the 0.2 to 0.4 mg per kg. If I've got the 1-year-old lab bouncing off the wall, I might do the 0.8 to 1 mg per kg. Do you see? So usually there's a range for these dosages, and whether you go up or down. Australian Shepherds, now boxers definitely have a sensitivity. I usually don't use ACE in boxers. Giant breeds, remember, you use the low end of the dose. They have a more profound effect. There is a note here at the bottom that you need to know. The maximum dose in a dog is 3 milligrams. If you have a 200-pound Mastiff and you calculate even the low end of the dose, you might get 4.5 milligrams. I max them out at 3 milligrams because usually that's enough for these big dogs. So it does have a maximum. It says don't go over this dosage. If you overdose, you treat the symptoms. The big thing I worry about when I give acepromazine, if they're too sedated, then I need to monitor their mentation. I need to monitor their vitals. If I overdose them and it causes vasodilation, I worry about low blood pressure. And how do I treat that? I give IV fluids. So if you give too much acepromazine or an owner overdoses them, usually we put in a catheter. I worry about hypothermia, so we put them on blankets. We put them on fluids for vascular support, and we monitor their mentation. That's how we treat an acepromazine overdose. All you can do is treat the side effects because you cannot reverse it. And that might be why sometimes people would rather use dexdomitor as their sedative, because they can reverse it. They can't reverse acepromazine. If you get into trouble with dexdomitor, it has a reversal. But I love ACE. I used it a ton. Now, when dexdomitor came out, dexdomitor gained a lot of popularity, but acepromazine's an old standby, and I'm old. I use this like water sometimes in every patient. And it can be given appropriately, but you need to know what to look for if you give it. So since it's 11, I'll stop there. Does anybody have any questions about anything I talked about with atropine, glycopyrrolate, or acepromazine?